A 4-year-old African-American boy is brought to the emergency department for fever. Since returning from a family trip to Nigeria last week, he has been lethargic with constant nausea and headache. He has had several episodes of vomiting and watery diarrhea each day and high-spiking fevers, chills, and drenching sweats every other day. The boy carries the sickle cell trait and has no other medical problems. He takes no medications and his vaccinations are up to date. His temperature is 40 degrees Celsius or 104 degrees Fahrenheit. Blood pressure is 90/60th of a millimeter Hg. Pulse is 130 per minute and respirations are 24 per minute. Examination shows a tired-appearing boy with jaundice. Lungs are clear to auscultation. The abdomen is soft and non-tender. Hepatosplenomegaly is present. Range of motion in his neck and extremities is normal. Laboratory studies show mild anemia and thrombocytopenia. What is your differential diagnosis? This child's clinical presentation is concerning for malaria, a dangerous parasitic infection transmitted by mosquitoes in tropical regions worldwide. Almost 2,000 people die from malaria every day. Plasmodium falciparum is the primary cause of morbidity and mortality in sub-Saharan Africa. Cyclic fevers, for example, every 2 or 3 days with other non-specific systemic symptoms like non-specific malaise, headache, nausea, vomiting, abdominal pain, diarrhea, myalgia, pallor, jaundice, and petechia are the key features of malarial illness. The febrile paroxysms parallel the waves of red blood cell invasion when parasites are released from the liver into the bloodstream. Diagnosis is confirmed by microscopic visualization of game-sustained parasites on thick and thin blood smears. Carriers of the sickle cell trait are inherently protected from severe disease, as the misshapen red blood cells create a suboptimal environment for parasitic proliferation. Patients with a past history of malarial infection are also at relatively low risk for severe disease on reinfection due to partial immunity. For prevention, we can use anti-malarial drugs like doxycycline, mefloquine, chloroquine, and hydroxychloroquine, or insecticide-treated nets and household insecticide residual spraying. Acute hepatitis infection can cause fever, abdominal pain, nausea, vomiting, diarrhea, hepatomegaly, and jaundice. However, this patient's cyclic fevers are suggestive of malaria rather than hepatitis. Meningitis causes fever and severe headaches, but patients usually have neck stiffness and photophobia as well. In addition, bacterial meningitis causes precipitous neurologic decline within hours of onset. Both sexes are equally susceptible to malaria. However, infants and young children are at increased risk for life-threatening complications, such as cerebral malaria, for example, seizures, delirium, coma. Ciprofloxacin is not recommended for malaria prophylaxis. It can treat travelers' diarrhea caused by Escherichia coli, Campylobacter jejuni, Shigella, and Salmonella. However, bacterial enteritis typically resolves within 5 days and would not cause periodic fevers.